I would like to say good afternoon for most of the people from Africa and good morning from those from USA and others. So I would like to welcome you all in today's session and to this knowledge sharing platform of the African Cancer Research and Control ECHO program. My name is Annette Nakaganda, a cancer epidemiologist based at the Uganda Cancer Institute. I'm the chair of the steering committee for this African Cancer Control ECHO, and I'll be leading today's session. A special welcome to those attending the Africa ECHO for their first time, especially the cancer registrars and cancer registry staff from Africa. And as you may have heard already, this ECHO aims to expand and sustain best practices for cancer control planning and implementation, as well as increasing the utilization of evidence in directing the cancer control effort in the region. So today, we are lucky that we are really having one of the most important aspects of cancer control and generating evidence, and which I think we have never had a session like this before. So it is really very exciting that we are discussing about the impact of the pandemic on cancer surveillance and cancer registration. And we really want to explore, because it looks like the pandemic is going to stay for some time. So we want to discuss and explore opportunities for creating innovative solutions to ensure that we continue strengthening the cancer registry implementation in Africa, despite such things that we are having. I therefore welcome everyone once again to this knowledge sharing platform. And before I invite the first speaker, I wish to remind you that we shall have two short presentations as detailed on the agenda you have. And I would also like to remind you to mute your microphones, please, if you're not speaking. This will allow us to avoid any interruptions. And if your bandwidth permits, please turn on your video, as we would like so much to see your faces during this interaction. In addition, please use the chat window at any time to introduce yourself, ask questions, or make any comments. And I also want to remind you that sessions are going to be recorded and it will be sent out to all of those who shared their emails with the African Cancer Control Research and Secretariat. So I want to invite now, I'm greatly honored to invite our first speaker from South Africa to share her experience about cancer registration activities in the pandemic and how the COVID-19 pandemic has affected this. Allow me briefly introduce Lerato Kwadi, who is a medical scientist from South Africa, and who joined the cancer registration practice and professional in South Africa National Cancer Registry under the directorship of Dr. Elvira Singh in 2013. At the National Cancer Registry, Lerato played a role of being an operation manager for the ongoing pathology-based cancer registry. In addition to that, she also worked very well in advocating for implementation of government's compulsory Cancer Reporting and Registration Act at different Ekurhuleni health facilities in South Africa. She played a leading role in establishing the Ekurhuleni Population-Based Cancer Registry. And this registry, she works as the project manager responsible for overseeing both active and passive case finding. She frequently visits data collection sites, addressing any operational challenges while evaluating validity and completeness of the data collected. Lerato is currently completing her master's degree in epidemiology and biostatistics studies at the Wits University in Johannesburg, South Africa. And she's really committed to make sure that evidence to support cancer control through cancer registry is actually strengthened throughout. So Lerato, we are really happy and honored that you have time to share with us your experience of cancer registration during this pandemic, and please, over to you.
Thank you, Annette. Let me just share my slides. Okay, so can everybody see? Okay.
Yes, I can
yes,
see the slide. Sorry.
All right. So Lerato Khwadi has already introduced, and I want to present our struggles with the COVID pandemic when it comes to active surveillance in our Ekurhuleni population-based registry in South Africa. So one of the things that we have seen is that South Africa being, sorry, I have a problem. I want to move you guys somewhere. Okay. No, that's fine.
Okay.
South Africa, just to give you a background, South Africa, the South African government passed a regulation which made cancer a reportable disease since 2011 that enabled the NCR or Cancer Registry to establish population-based registries. The Cancer Registry chose the Ekurhuleni district, which is in Gauteng, as our first urban population-based registry in South Africa. One of the reasons being Ekurhuleni has a well-defined population of about 3.3 million people and is demographically very similar to the general population of South Africa, both with race and socioeconomic status. Despite the fact that we had regulations from the government, passive reporting from our healthcare facilities was a major problem. Then the NCR resulted in employing 8 surveillance officers for active data collection since 2017. So since 2017, we've had active surveillance that was done at Ekurhuleni health facilities, which basically covered all public hospitals, hospices, and most of the private facilities. We also have 3 tertiary hospitals in Gauteng, which is what Ekurhuleni is part of, where patients from Ekurhuleni are usually referred to for oncology treatment. Now, all these facilities usually give us full access to abstract data in all areas as we deem necessary. Then COVID hit very hard in South Africa. The numbers are still rising. We are currently ranked 5th highest COVID positive country in the world. And unfortunately, our Ekurhuleni also is an epicenter for COVID. Now, because of all those rising numbers of COVID, all of our areas that we are doing active surveillance do have COVID treating areas. So they do what they do, like everyone, abide to the restrictions laid by the WHO, and then plus other facilities will put their extra rules because, doing what is suitable basically for their special needs. So when the pandemic started getting into South Africa, like I think most of the country, we had a complete lockdown that was imposed by the government for about 6 weeks, which meant that in that 6 weeks, no active case finding could be done. Then lockdown rules got relaxed from the 1st of May, meaning that we could do now active surveillance. But then when the surveillance officers went back to the hospitals, we found that it wasn't business as usual. For example, when they went to hospice, no one was allowed there because hospice has the most vulnerable patients that they are taking care of. And then we got excited because all of our hospitals allowed us entry. But then we got excited way too fast because the wards that we usually get most of our cases at is a no-go area for us. The wards either have COVID positive patients or very sick patients who are still waiting for COVID results, so they don't allow us at all to get into the COVID areas, the wards. Now, another thing is that we have now the hospital clinics, which are opened for us. And of course, we said at least we can get something to do, you know, active case finding there. But most of them, every now and then, they get closed because the hospital staff would be testing COVID positive. So they have to get closed so that they can disinfect the areas. Now, other clinics are very, very strict. They would allow the surveillance to come in, but they won't allow them to touch their files because they feel like it's not safe. I think we will all agree that COVID, when you're doing cancer registration, hospital files are very important. So in our case, most of our hospital files are electronic, but you can access them through the hospital intranet, which is mainly at the admin clerk stations. Now, these clerk stations are very small and overcrowded. To keep social distancing, the clerks have now to they are now working in shifts. And as soon as they do shifts, then our surveillance officers are not counted because we are not part of the hospitals. And then, of course, it's an open secret that the whole world is panicking about this pandemic. But we as Cancer Registry, have we ever thought how our surveillance officers are affected by this? Because unlike people who are office-based or those who can work from home, they are constantly facing the impact of the pandemic at their surveillance sites. And they're working up and down in our very old and poorly ventilated hospitals, which are a health risk themselves. Now, this clearly will increase anxiety and stress in our surveillance officers. So what can we actually do about it? One of the things that we could do is that normally what we do is to give them a face shield and then a mask and gloves. But when you go into the hospitals, you see people in full hazmat suits and all that. So what we could do is to actually provide our surveillance officers with the PPE that's similar to the hospital staff so that they can feel less vulnerable to this COVID. But, you know, it will mean we are taking money, we're talking budget. Okay, just leave it there. There's a lot of things. Economy, what. Anyway, what is nice about the NCR is that we have free professional counseling service that's available to us 24/7. And we also can test COVID anytime as a free service. So one of these things, these free services that we have, this is the time to actually encourage them, our surveillance officers, to actually use these free services. One of the problems that we see at the hospitals is that the hospitals are empty. Patients are scared of going to the hospitals. Most would rather stay at home with a huge lump on their breast than to go to the hospital, fearing they would contract coronavirus at the hospital. Now, with all these things that have just changed and all the restrictions of active surveillance and everything, what we see is that we'll have gross underestimation of our cancer incidences during this pandemic. For example, we have one of our hospitals, we would normally like report about 100 cancer cases per month, and it's struggling to get 50 per month because of all the restrictions and where to go, where you cannot go. So what I think is going to happen is that if we have to make serious changes, and perhaps the platform could give us maybe ideas of how to do these things, because if you leave everything the way it is and say it's business as usual, during the pandemic, we're going to have very low cancer cases. And then post the pandemic, we're going to have a huge spike of many patients that would come to our surveillance sites with highly advanced cancers of very poor prognosis, which will affect our incidence, mortality, and survival studies. That's all I have for you. Thank you very much.
Oh, thank you so much, Relato, for such really an awesome presentation. It really shares most of the dilemmas we are facing in our setting, where we really have challenges, where the records, the author records are not interlinked and so on. So, dear colleagues, once again, as a point of reminder, please take note of your questions to Relato, or use the chat window to post your question or comment. And then, as I said, we shall have protected time at the end to have detailed discussion on the way forward and on how we can improve cancer registration during the pandemic era. So at this time, I'm greatly honored to invite Anne Corey to really give us a didactic, an expert view on the situation and how it is. Anne Corey is a senior research scientist from Kenya, working at the Kenya Medical Research Institute, commonly known as KEMRI, in the area of non-communicable diseases, mainly cancer. She's a pioneer in establishment of population-based cancer registries across various counties in Kenya, and actually countries in Africa. And she's currently the head of Kenya National Cancer Registry at KEMRI. Anne is an epidemiologist, and her focus is on epidemiological research and surveillance, with an aim of generating quality data that actually informs policies and implementation of cancer control interventions that are aimed to improve health outcomes among communities. She has served on African representatives in the International Association of Cancer Registries, that is IAC, and currently supports the Africa Cancer Registries Network to expand cancer registration in Sub-Saharan Africa. And we are really happy to have you and excited to hearing from you. Please take the floor.
Thank you so much, Annette, for that introduction. Thank you as well, ECHO team, Mishka, Annette, Christine, the entire ECHO steering committee. I wish to really thank you for considering this topic, which is very, very important to us as cancer registrars. And I extended this invitation to our cancer registrars in Sub-Saharan Africa. And so I welcome all of them to this meeting, because this is really about what they do, and we expect that they will contribute to this presentation. So thank you, Lerato, for that very, very exciting presentation. Really, whatever you have raised is what resonates, with many of us. A lot of us are facing similar challenges. And so we're really grateful that you could share your experience in Ekurhuleni in South Africa. So I think we all know about these statistics. The global estimates currently stand at more than 18 million, and new cases, and more than 9.6 million deaths. And this was as at 2018 data from the GloboCan. And we all know that the overall risk of getting cancer also was estimated to be 20% on average. And we've really seen many of the cancers that are prevalent. We've seen that prostate cancer has come up in this last data that was presented by GloboCan. Prostate cancer came out top, and breast cancer for women were also some of the leading cancers globally. And when we go closer home, sub-Saharan Africa, we can see that you know, the burden of cancer as well is really, really high in this population. And more than 70% of the deaths are actually from the low and middle income countries, according to this data that was presented by WHO's GloboCan. And the biggest burden is on breast, is among the women, where we see breast cancer being most prevalent. And in most of the countries, especially the East Africa countries, we've also seen that cervical cancer is predominant in most of these regions. And we all know that cervical cancer is preventable if we adopt you know, measures that most of the developing countries have adopted. We've seen that there's significant reduction of cervical cancer in the developed countries that you know, initially from the beginning adopted strategies like screening, you know, early detection, early treatment. These are some of the things that we have not done very well in sub-Saharan Africa, and that's why we still see cervical cancer being a major problem. So if you look at on the chart, the chart on your left-hand side, you can see that some of the prevalent cancers are breast cancer, cervical cancer, prostate cancer, colorectal, in that order. So those are the top 4 cancers as far as incidence is concerned. And then you can also see the number of deaths. So if you look at the number of cases, more than 750 cases, 1,000, and more than 500 deaths. So the biggest challenge in Africa is that cancer is diagnosed, you know, at late stages. Of course, there are many factors that contribute to that. Not necessarily the patients going to facilities late. Sometimes it's the health system that is frustrating care in this part of the world. But you can see that mortality is very high. You know, when you look at the number of new cases vis-a-vis mortality, mortality is really very high. And this is what probably we need to work on as Africa. So this data actually is from registries, and without registries, we will not be looking at those figures. So I put in those figures just to emphasize that this data originates from cancer registries. And without cancer registries, then we will not be able to even know what is happening in the world. So registries play a major role. And, you know, in terms of generating this data, because this data is so important for research, it's so important for policy guidelines, and just for informing cancer control interventions across various countries. So it's really important to embrace cancer registries in our various countries, because it is through them, or rather through their work, that we are able to get informed, you know, data that really informs our decisions. So cancer registries really lay a foundation for evidence-based scientific research, right? So if you really want evidence-based research, then you need to have registries, because then they guide you. They're able to tell you where the burden is, which group is more affected, where should we put our money, where should governments put their money when it comes to cancer control, right? In Africa, for example, probably would not know that cervical cancer is killing a lot of our women, and therefore our governments need to put in money into preventing lots of lives being lost, you know, to cervical cancer. So our governments need to put money into screening, early detection, vaccination of young girls, because this is where the problem is. So these registries really play a major role in informing governments to make the right decision and to utilize the resources that they have, because we have limited resources. So we need to utilize those resources, you know, adequately. So registries enables us to do research, enables us to identify, you know, high-risk groups and be able to channel our interventions to those groups. For screening programs, you know, we are also able to monitor screening programs, and we would like to see a situation where registries are linked to the screening programs as well, so that we are able to monitor, you know, the patients right from screening to even, when they begin care, if the tests show that they have cancer. So if we go closer home to sub-Saharan Africa, I just put in a slide there from AFCRN, and you can see some of the countries in Africa, in sub-Saharan Africa, that have registries, and it's really pleasing to see that most of the countries at least have a registry. Before, we used to have, I think, 1% in sub-Saharan Africa having registries, and they used to be Uganda, Zimbabwe. Those were the only countries that, were having population-based registries. But we can see now that there's some improvement. We have many countries now with very good population-based registries, and mine is just to encourage my colleagues to really work hard as far as quality of the data they generate is concerned. There's one thing to have a registry, but there's also another to ensure the data generated is of high quality. And that is what our global partners emphasize. AFCRN, the network that coordinates the registries in sub-Saharan Africa, really emphasizes the quality of the data. You'd rather have one population-based registry that produces high quality data than have 10 that really do not produce data that can be used to make informed decisions. So Africa Cancer Registries Network is the network that really brings together all the cancer registries in sub-Saharan Africa. And it is like an umbrella body for all the cancer registries. And we usually meet once a year, every year, to deliberate, to discuss, to share the challenges, share opportunities. And, because of COVID-19, we've not been doing this. Actually, the meeting that was to take place this year was canceled because of the COVID-19 situation. But we hope in the future, we can continue to interact through this platform because it also motivates the cancer registries. When they see other registries are doing well, it motivates them to also work hard on their data and, make improvements for their registries. So again, to be a member of AFCRN, because I'm saying this because I know a lot of registries are connected today, you need to ensure that your registry is at least 50% complete in terms of case finding and abstraction. And that brings us to, again, this topic, because of the challenges of COVID, how are we doing in terms of completeness for our registries? So if we look at this survey, this was done by IAC, International Agency for Research on Cancer, and they did this survey. I know a lot of us received questionnaires asking us to, to explain, or rather to, to state whether we have any challenges as far as COVID-19 was concerned. And I'm very sure most of us were able to respond to that survey, and you can see that a lot of countries stated that they had challenges. You can see Africa there, a lot of the blue regions, these are registries that responded to this survey and stated that they were affected. So the blue states that these are registries that had challenges as far as COVID is concerned, and you can see a lot of the registries really have challenges, or rather are facing a lot of challenges as far as COVID situation is concerned. And these challenges range from, staffing, range from funding being, reduced, and all the challenges that Lerato presented. Restrictions to go to the facilities to collect data. So these are the many, many challenges that most registries are facing. And Lerato already presented that. I will not go deep into it. But, we all know as well that in sub-Saharan Africa, apologies for that background noise. We are just next to the airport. Sorry for that. So we know that most of our work is largely manual. I know that people from the developed nation may not understand what I mean by that. I would need to take you to the facility and show you physically. But our work is largely manual in the sense that we go to the facility, we retrieve a patient file, a physical file. It is not an electronic file, it's a physical file. We retrieve the file and then we fill in a paper form. So you actually go through the file, you read it, as you document the data you need in a case registration form, which is in paper format. So this is the kind of work that most registries are doing as far as case finding and abstraction is concerned. So when COVID situation presented, and with all the restrictions to ensure that the disease was brought under control, obviously this work was interfered with. One, as we all know, there were restrictions as far as movements were concerned. But even in situation where it was okay to move, we also found it challenging to send our staff to the facilities, knowing that there was risk of infection. And so most of us were asked to limit sending our staff to the facilities. Specifically here at KEMRI, we were actually told not to send our field staff to the facilities, so that then we are able to protect them as well. So obviously this work was brought to a halt, okay? So, so these are some of the challenges, and Lerato presented these, a lot of the challenges that we are currently facing. It's because for us to do our cancer registry work, we have to go manually to the physical facility and abstract the data from the patient file, and then submit the forms to the cancer registry for data entry to be done. So when this process was stopped, obviously the work was affected. We've also seen other things like interference as far as treatment is concerned. There are less patients that are visiting the facilities now for care. Does it mean cancer has stopped? No. These people, they still have cancer, but they are preferring to stay at home because of fear of infection in the facilities. So some of our facilities where we collect data from, they tell us, but the patients are not even coming. Patients are not coming to the facilities for treatment. So there is also a major problem as far as treatment is concerned. Registry data, of course, will go down this year if we don't adopt new ways of doing our work, but they will also go down because the patients are not visiting the facilities. The patients are opting to stay at home. So these are some of the challenges we are experiencing. We usually do follow-up of our cases. Of course, that is also a challenge because we normally do follow-up in the facilities. We go to the facilities to check, have the patient come back for care? If they had, 3 sessions of radiotherapy, 6 sessions, did they come for all the sessions? And we document that. But because of the COVID-19, this has been interfered with. There are psychological effects, even to the registry personnel. Initially some of my staff said, oh, we are bored staying at home. We want to go to the facility to collect the data. Okay, I allowed them to go. I purchased PPEs and, but when they went there, they again faced trauma because for some of them, the COVID ward, the COVID patient ward was next to the cancer center. And so there was this psychological effect of, you're seeing COVID patients and you're there doing cancer registry work. So there are all these challenges that healthcare workers are facing, the fear of infections, and just the psychological trauma of all these situations. Then, of course, the issues of funding. Obviously, the funding for registry work will also go down. A lot of the funding is being channeled to COVID, to address COVID. Even for our government budgets, a lot of the budgets are being redirected to COVID. So if you were to apply for a grant, or if you usually get some funding for registry work, this funding is likely to go down because of this situation. So these are some of the challenges. I know there are many challenges, and I know I'll be hearing from most of you in the discussion. But what are some of the opportunities that we can embrace to address this situation? Okay, so there is an opportunity really for EMR systems, for adopting new technologies, adopting new ways of, carrying out our activities. I think Africa, for the longest time, has resisted or really not adopted technology as they should. I feel like this is an opportunity for Africa to embrace technology, to adopt new ways of, undertaking their activities. And one of the things really for the cancer registries, if we had EMR systems, I think our work will be much easier. I was trained, part of my training, I did it in the US, in one of the registries in the US, and I saw how they worked. Registry personnel were empowered to access the EMR systems in the facilities, and registrars actually worked from home. It's interesting that now we are being told to work from home, but there are registries in the US that were working from home for the longest time. I went there many years ago, and their registrars were actually working from home because they would just log into the hospital system and access the data that they need and extract or export that data into the cancer registry database. So we need to learn from people that have done this. It is not a new thing that we are studying. It is not, we are not innovating, coming up with something new. It's something that has been happening. So Africa needs to really wake up and change their ways of doing things. I don't think, I know that even, the registries in the developed countries may also have their own challenges, but really they are still able to access the data without necessarily visiting the facility. Our challenges is we have to visit the facility to access data to the cancer registry. If we had EMR systems, then this would really change, because all you will need is some login information and be able to log into the system and still do your work. Cancer registrars are health professionals. They are not random people from the streets. They are people who are health professionals who have been trained on confidentiality, on ethics, and they will be able to observe that as they do their work. So for, my thoughts really are that we need to move away from, the fears of confidentiality, because we are employing healthcare workers. They're the same workers working in the hospitals. They need to be empowered and given the resources to access the databases and be able to still compile their data. I know that patients are not visiting the facilities now, but what can we do also to ensure the patients still communicate to their oncologists? We can adopt platforms where oncologists and patients can interact. And I think such platforms will need to be linked to the registries so that then registries are able to also extract the data that they need. Already we are adopting online trainings. I know we are already doing that for Kenya. We are doing that in AFCRN, just adapting new ways of doing things. We were used to, organize trainings where people need to come and sit. Of course, that is still important because some of the work is practical in nature and people need to still meet. But I think we could still move, and during this era, still do some capacity building for our staff by adopting these new ways of using technology to do our work. And we also need to probably increase follow-up of our patients through mobile technology. A lot of our people have mobiles, even people in the rural areas, they all have mobile phones. And so we could still be able to maintain, at least understand how they're doing and be able to still update the data in the registry through contacting them on their mobile phones. So of course, what I would recommend really is for the facilities in sub-Saharan Africa to adopt EMR platforms. And we have very many centers, we have diagnostic centers. A lot of the labs, especially here in Kenya, they have some form of electronic systems. What we need is just for them to ensure they are collecting the kind of data the registrars would be interested in. The challenge is that some of these systems do not collect the kind of data that we need. You are interested in collecting residents so that you know where to place this patient. You find they have not collected residents. You're interested in collecting age. You find they've written adults. So we need to probably, sensitize the facilities on the importance of these variables that are required in the registries, so that these systems can then be linked to the cancer registries for the cancer registry data to be compiled. So I already talked about the EMR systems. That is really important. And so as I finish, I thought I'd just share a little bit about what we are doing here in Kenya. So we are currently trying to empower our personnel. I cannot say we've done it adequately, but we are reaching out to our staff in the counties. We are organizing Zoom trainings and empowering them to actually continue doing the work. the pandemic is highly in the urban cities like Nairobi, Mombasa. But in the other counties, the pandemic is not so much in these areas. And so we are empowering the staff in those facilities to continue cancer registration. So we are doing online trainings, online technical support, so that then some of the work can still continue even during this pandemic. We tried to provide some PPEs to staff, but again, we realized that it was too much of a risk to send them to the facility. So that work has really stopped, especially in Nairobi. Our registrars are not going to the facilities at the moment because the pandemic is really, because of the high spread of the disease at the moment. We are also trying to establish the linkages with the existing systems that have EMRs. Some of these are in hospitals. So there are some hospitals that already have EMR systems. We are trying to link those systems to the registry by exporting the data and importing it into our database. We have also contacted NHIF and reached out to them so that we can also get the data that is in their database to also link that into the cancer registry. And our plan are to reach out to the other insurance companies as well, if we can be able to get that data and link that to the cancer registry. And also exploring linkages with the pathology network. The pathology network mainly has data on diagnostics. They will not have data on treatment, unfortunately. So you will still need to make a visit to the facilities to link that data to the facility data, because the facility data has treatment information, which is not available in the pathology data. But we think even getting to know that we have some cases that are diagnosed with cancer, even if we don't have treatment information, we can follow up later when there's opportunity to do that, to still update the treatment information. Okay, so, and then the other thing we've done also is to develop a digital platform so that our registrars move away from the paper-based system. So instead of the registrars visiting facilities with paper, they are now entering the data into some digital platform. That also reduces the many stages for data processing. You know, when you abstract data on paper, you have to enter it again in the computer. But if you do it direct on a digital platform, that data goes straight into the database for further analysis. So those are some of the few things we are doing. And I know that most of the registries are making an effort to do something during this pandemic. Mine is to just urge everyone to think outside the box, to explore and to be innovative, and so that we ensure that we still continue with our work despite the challenges. Let us learn from our colleagues that have done this. I know a lot of our colleagues, you know, have been able to adapt some of these technologies. Let us adapt that and ensure that in the end, we are still collecting data for our registries. So that is really what I wanted to share. And just to emphasize that, you know, continuous cancer surveillance is necessary for monitoring the trends in cancer occurrence in our various countries. And it is also important for patient care. So there's need really for us to continue doing this work so that we can inform cancer control programs in our countries. And we need high quality population-based registries in sub-Saharan Africa. We need really to move towards generating high quality data. I see COVID-19 not as a hindrance, but as an opportunity. This is an opportunity for us to really think of new ways of doing things and embrace new technologies for our registries. So I wish to thank all of you for listening to this, and thank our organizers, the ECHO, the US Center for Global Health, NCI, KENCO, and all our international partners, IAC, GICR, AFCRN, and most importantly, our cancer registrars. You do amazing work, and I wish to sincerely thank you. Thank you, everyone.
Yeah, thank you so much, Anne-Corrie, for really such a great, awesome presentation, thought-provoking, and with very excellent suggestions and consideration for cancer registration during the pandemic, but even on the way forward. So members, you are welcome. now with your questions, ideas, perspectives on how we can move on. As Anne Corey said, that we should actually embrace opportunities that comes with a pandemic, and with the saying that when it rains, look for the rainbows. So let's see how we can move on, because it is really quite a challenge, and it is something that cannot be done within a year or 2 or 3 or 4, knowing very well the African setting. So you can speak out or put your comment or ideas and questions on the chat. And I think some people posted some questions on the chat window. As we try to pull them out, feel free please to put up any comment. Thanks. Yeah. Let me see. Oh, sorry. Oh. Yeah, I just want, there are some questions on the chat window. Mishka, do you have?
Yes.
Let me see. I was trying to summarize them here. Let me see if I can project the slides. And see. Yeah, to start with, I think if you can see my slide, there's a comment from Mariana saying, does South African surveillance team have an operation plan that will be updated with all of the important lessons learned from their work during the pandemic, so that it is documented for use in other emergencies and times? I think, Anne, would you like to take a go on this? Anne, are you there? Can you unmute yourself, please? Sorry. Anne, you are...
Yes, I am unmuted now, Annette.
Yeah, maybe you take a go on whether there is anything in Sub-Saharan African network that we can really update on the lessons learned and continue to work on the cancer registration efforts.
Okay, so I don't know if Being is in this meeting. I think she would be the best to answer that. But I know we have a platform where we share ideas, we do discussion, we raise any challenges that we are facing. So that group is being operated by Being. So I do not know whether the best thing would be to share Being's email so that then some of these questions may be directed to her. But yes, there's a platform where all the cancer registrars from Sub-Saharan Africa are connected. Like I said earlier, we usually have an annual meeting where we meet physically to discuss and share ideas. But because of the COVID, we are also thinking of new ways of doing things. One of the first things that we are working on under AFCRN is to come up with an online training for cancer registrars in Sub-Saharan Africa. So the rest of the things, I think, like some of our meetings that we used to have physically, we might also go to an online platform. So those are some of the things that we are doing. But I think Being is connected. Maybe Being, if you like to add to that, you can unmute and take it up.
Yeah, thank you. And Being, if you would like to add on this, please unmute yourself and introduce yourself briefly, and then add something on Anne's comment.
Hi, everyone. Sorry, not the best time for me to talk. I'm having children around me. It's okay to share my email address to everyone, and everyone can pop questions to me anytime. Okay, my apologies. Not the best time, sorry.
Okay, I will send Being's email to Annette, and Annette can share that as she is sharing the presentation.
Yeah, thank you so much. I know, and if you may agree with me, I think the African Cancer Registry Network doesn't have an operational work plan, because it is mainly concerned with building capacity and improving the quality of cancer registration in Africa. I think this is left to the individual countries to make sure that they incorporate cancer registration and what they need to do when it comes to cancer registration in their national cancer control plans.
Yes.
To my knowledge, this is, most of the countries are now drafting their cancer registry plans, but we had never thought of prioritizing the infrastructure to do with the electronic system, because this infrastructure is not only going to happen only in cancer registration. It will not even happen in the cancer registries unless it happens in the health centers and in the cancer centers and in all hospitals where are the sources. So the challenge is the electronic medical system. We have the HMIS, the district HMIS, but it is quite difficult when it comes to cancer because they just register anything. Duplicates are not sorted out. One person may be registered by 10 health centers and they don't use it always. So the attitudes, the practices, and even other things that go with it when it comes to the whole infrastructure, internet access, ICT, computers, capacity. So it is not a single issue that is going to be sorted out by cancer registries alone, but I think the whole national cancer control planning and priorities. So we go to the next question that was from Emmanuel Trilato for the, I don't know. Can you hear me?
Yes.
Yes. Thank you. Something happened. Yeah. So for Trilato for the presentation. So Dr. Emmanuel Rilika from Uganda thanked you so much for the presentation, and he's wondering whether there are other cancer registrars outside the Ekurhuleni, and if so, are the challenges the same there, both in rural and urban setups? Which level of hospitals does the registry work with, and is it all the hospital selected levels? So, Rilato, would you like to have a go on this?
Okay, we do have another cancer registry, which is at the Eastern Cape. I think we are most familiar. That's the South African oldest cancer registry. It's a rural one, which is run by Ntutu. I think we all know. But looking at the challenges that they have, even in the rural setting, because the Eastern Cape was one of the pandemics as well, like the epicenters as well. Looking at the challenges, we have very, very similar challenges. And when Anne was talking, I could hear that it really doesn't matter whether I'm in South Africa or I'm in Kenya, we do have the same problems. So I don't understand the question that says, which level of hospitals does the registry work with?
Yeah, just to interrupt a bit, I think in some settings, I think especially in East Africa, we have Health Center 1, Health Center 4, district hospitals, regional hospitals, and then national hospitals. So I think those are the levels that he's meaning. Okay,
so we have basically our regional hospitals. Okay, district hospital, we've got actually only one in Ekurhuleni. And then the rest of them are regional hospitals that we know that all our cancers will be diagnosed there. So our lowest one, which is one, will always refer to our regional hospitals. And then we have the tertiary hospitals, which I have already said there are 3 now that we are working with, because they're around, not far from the Ekurhuleni, and we know Ekurhuleni hospitals refer them there. So the tertiary hospitals are normally the ones with huge oncology units that are actually there to treat, they've got specialized oncology treatment.
Yeah, thank you so much, Rilato. That was really a very great experience. And again, Evans had a comment also on the chat saying, he mentioned the availability of electronic data in the different facilities in Sub-Saharan Africa. Is it possible, in in South Africa, is it possible to utilize this method to abstract the data? This can be an option. So thank you. So I think it is being agreed even on the chat window that we have to go away from paper-based to electronic-based. And many people had comments. Rwanda, Francois has said they have started linkage. Francois, would you like to share in 1 minute how this is going? Because you're saying that you have started integrating cancer registry data abstraction from the DHSI2. And is it working? Please let us know how it works. Francois?
Haronit?
Yes. Would you like to share in more detail about how it works? The linkage of the cancer registry data to the DHSI2. Please.
Okay, thank you so much. And yeah, I joined a little bit late, but I can provide just in 2 minutes what we are doing. So maybe there are two projects. The one is linking directory electronic medical record systems like OpenMRS or any other electronic medical record directly to our cancer registry, so that we can maybe from the central level pull data from those electronic medical records. That one is really, I mean, we have started working on it, but it needs more expertise, IT expertise, things like that. But of course, we are working with IAC being knows. So yeah, it's the work in progress, but it's possible. But as Anne said, we need to make sure that those variables that we need for our cancer registry, we can get them from those electronic medical records. Sometimes you might find that the information that they are capturing in those EMRs do not really match with what we need for our cancer registries. So it's also a work that has to be done on those electronic medical records. So the second one is the DHS2, I think being used, I think in all countries, part of the HMIS. So this one is, they say, it saves time for data collection. Sending cancer registrars down there to their facilities to do manual data collection, abstraction, and then come back to the central level for, data entry. So for this one, we have done like an individual tracker into DHS2, so that we have trained cancer registry for co-persons in all district hospitals. Now they can now do data abstraction, and then do report directly data to the central or to the National Cancer Registry through DHS2, so that people at the central level can now download what they have reported, make some quality checks, and then upload into Canreg 5. So it saves money, it saves time, and also it makes things move quickly. But also something good also for DHS2, before entering a new patient, you can check to see if, it was not there. So you can, if the patient has been, let's say, recorded from facility A, maybe they have put some few information, but there was some missing data on, on the treatment outcomes and what. So once the patient goes to facility B or C, they can, before entering that new information, they can check to see if the patient was not there. And if it's really a patient that was already in the system, they can add only that new information that was missing, no need to enter again the same patient for the second time. That can also bring some duplication. So quickly, that's what I can share. Maybe it's a work in progress. We'll be able to share the outcomes maybe just in a few months to come. Thank you.
Yeah, thank you so much, Francois. That was interesting. But in the interest of time, we really need to close this discussion. And members are welcome to continue the discussion on the best camp. To really sum it up, it is like challenges with the pandemic can't allow us to continue with cancer registration practices of active and going to the units the way we have been doing. We have to move on to the electronic system. But as Amaka from Nigeria has really commented on the chat, that actually we really need this, and there is need to assess the facilities on the ground and the best way to go. And other than, because we really need the sources to be ready to provide this electronically. And some other questions on the chat were about more of technical. Can CANREG import or export in Excel? I think it can. And they were asking Anne-Corey which version of CANREG is using. CANREG keeps on updating this, and I think Anne and Being can help answer these technical questions in great. So thank you so much. It looks like we have to end now, and I would like to invite Mishka and Christine if they have any announcements. Yes, Mishka or Christine? Yes, Christine.
Yes, thank you so much for logging in today's session. And thank you to the case present. Thank you to Dr. Lerato and Dr. Anne. Our next session is on August 6th. The topic is on country strategies for reopening cancer care services amidst the ongoing pandemic. We do not have presenters as at now, and we are requesting for volunteers. So please send us an email. You can either send Mishka or Annette or myself, please, for the August 6th session. Thank you so much.
Yeah, all right. Thank you, Christine. It looks like we have come to the end of the session. I would like to thank Lerato and Anne for sharing their great experience today. And thank you all for attending. And I look forward to seeing you in the next 2 weeks. Thank you so much.
Thank you so much, Annette.
Yeah, thanks.
Thanks, everyone.
Thank you.
All right, bye. We can leave the. All right.
Yes, I will close now. Thank you so much, you all.
And Mishka will
bye.
close. Yeah, thank you.
Thanks,
so much.
everyone.